Hi, I'm Dr. Samia Malik. I'm an outpatient neurologist at Sunshine Medicine Associates. I believe before diving into the science, what led me to do neurology was to the way that brain works and how it shapes us to who we are. It's like a detective work. You're trying to understand, listening to the patient's story, trying to put things together, and making sure what's happening before starting the imaging and things like that. So I guess that was the thing that drawn me to this specialty of neurology. I had worked in the inpatient hospital setting as well, and also the outpatient. The reason that I decided to continue with the outpatient practice was because I felt there was a lot of need in that area, because once the patients get discharged from the hospital, they do require some long-term relationship with a provider who can manage their neurological conditions. So it was based on long-term meaningful relationship that I can develop and small things that I can do in order to improve their quality of life. And that could be timely close follow-ups with the patients, monitoring their small progresses, and also trying to pick up the signs before it's too late. So I guess those were all things that made me motivated to go towards the outpatient neurology, so I can make an impact in a positive way in their lives. So we actually are lucky enough to be able to treat all the way from 3 months to I have the oldest patient like 103 years old. So I'm taking care of both pediatrics and adults patients. That give me a lot of freedom, because again, it's the continuity of care. A lot of kids, when they are turning into 18 to 21, they have to switch cares to a different neurologist, where the parents get a little bit nervous about developing a relationship with a new provider. Would they be able to understand their condition? So that allows me to continue their care. So I'm able to take care of them not just when they're pediatrics, but also when they are going towards the adulthood. Same is being in Florida, we do have a lot of population that is in the older spectrum. So managing their care is also very rewarding. So I feel very happy that I'm able to take care of wide spectrum of patients and taking their conditions into consideration and managing it in accordance. It's very important to understand that neurology is not just one condition, and I feel privileged that I'm practicing general neurology because I am taking care of all sorts of neurological conditions. A lot of providers you're going to find will be doing subspecialties, which is great. They are specializing in conditions like multiple sclerosis, epilepsy, neuromuscular disorders. But before we get to there, they do have to see a general neurologist in order to help them identify which directions they need to go to. So there's a lot of need of general neurologists out in the community, and I feel bad for the patients that some places have a wait time of like 6 months or more than that, where patients are not severe enough to be hospitalized but not able to see the provider as well. So they're hanging in the air. So I feel very happy that because A, we have more than one location, and B, we are able to get them in sooner and start their workup, because some neurological conditions, if you are able to pick it up sooner, then obviously the prognosis and diagnosis in timely manner helps the long-term treatment plan and also their progress. And answering the question about the different neurological conditions we treat, number one is migraine. I see migraine a lot, and I feel like it is underrated to the fact how much debilitating it can be to a patient's life, because migraine is just not a headache. It's like a combination of chemical changes, activation of pain pathways, inflammatory markers that can affect patients' life and their activities of daily living and social circle as well. Other conditions are epilepsy, multiple sclerosis, Parkinson's disease, Alzheimer's, neuropathy. I mean, we take care of anything and everything if it's neurology related. So Botox can be used in different neurological conditions. In our office, we administer Botox for patients who suffer from chronic migraines. And the good thing about is that the patient satisfaction and improvement in their migraine is tremendous. We do not wait for the Botox to be offered in the last. When we feel that a patient is candidate for that, they qualify for it, we are able to bring them in and do it in our office. It's given every 3 months. We explain everything to the patient, how it's going to be, what are going to be the signs and symptoms after the first treatment. So providing them not just the support that they're looking for, but also making them feel that they are heard and they are empowered rather than they feel overwhelmed. So Botox is one thing that we administer. We feel it is helping. Along with that, the other misconceptions that they need to stop their other medicines that they've been on for years, they can still be on it. And also there are some modifications to their plan, like offering them a nerve block when we feel like their Botox is like lingering off and it's not time for them for their next treatment. So there's so many venues that we can work on if we are able to make the patient understand and explain what our long-term goals are. So epilepsy is a serious condition that we cannot, take it easy. First of all, we need to make sure that this is what we say is epilepsy. I was trained in USF and I was lucky enough to be trained under Dr. Benbedis, and he would, teach about something that not everything that shakes is a seizure. So first of all, identifying what we are looking at. Is it actually epileptic seizures or the other one, because the treatment can be entirely different. So obviously the first thing is to identify and small signs and symptoms, and educating the family about little things like if they're able to record the episode, and clinically the symptoms before and after are really important. A lot of time patients can have subclinical seizures or in their sleep, so they get easily misdiagnosed. So identifying if it is epilepsy. Again, we offer in our office EEGs, which are done as a part of our diagnosis, or even have ability to do the long-term EEGs to make sure that what they are having is epilepsy, and then treating it timely manner. We are very lucky. We have so many options to pick from when it comes from medications, epileptic medications, and it's very concerning. Every time anyone has a seizure, it damages the brain. So our utmost, priority is to make them seizure free, and making them understand how important it is medication compliance and close follow-ups, their blood work to make sure their levels are fine, they're not experiencing any side effects, because the most common reason patients are not compliant is they may not like the side effects they're experiencing. So having that deep conversation with them and making them feel heard and supported, so then we can go in a direction where they feel compliant, that we are there to help them and making them seizure free, and that's our utmost goal. So multiple sclerosis is an autoimmune condition that is lifelong. So obviously when a patients find out they have multiple sclerosis, it takes time for them to accept it, because they are in a condition where they feel like now they're stuck with this for lifelong and there's no cure for that. However, we are lucky enough that the science has given us so many different immunotherapies that we can pick from, and half of my patients, even more than them, are living a normal life and nobody can even tell that they have this condition. So first is acceptance, trying to understand what they have is going to be lifelong. However, there are going to be days where they will not feel the best, but we are lucky enough to have those treatments which bring them closer and closer to the normal life that each one of us are living. And there's no problem, like they can get pregnant, they can have kids, they can do whatever they feel like in their life. There's no limitations. So my approach is, again, providing them the support, making them understand that they are being heard, we know where they're coming from, not that's just being treated as a number, and then providing an individualized care. It's going to be different for every patient. So having that feeling that they are being treated as an individual based on their personal requirements, and making them understand that if one medicine did not work, we have other options, and not get discouraged. At the same time, providing them other support, because this disease has a burden, and this is very common that they can get into depression and other psychological stresses which can be easily missed. So again, a multidisciplinary approach to them is a key that I have learned and I have practiced and has worked out for most of my patients that are working with me right now. Again, neurological conditions can sometimes be irreversible, and there are not a lot of, you can say, medicines that can reverse it or, can slow down. However, science has been advancing by leaps and bounds, and being in Florida, we do encounter a lot of these conditions which can be picked up by minor signs that patients are not even noticing that we as a provider can pick. So, little things that we educate them that helps them in understanding their condition. So, Parkinson's disease, before we get to the imaging, is mostly the clinical diagnosis, and the patients, if they, or the family members, if they experience that there are certain changes that they're noticing, and they bring it to the attention to the primary care, and they are sending the patients to us. So, we start off right away. There's no delay in their care, and the sooner we start their treatment, the better, outcomes there are. And we are lucky now, newer drugs in Alzheimer's, such as Leqembi, these are helping the patients, and their families are saying they see a night and day difference. However, they do need close monitoring and supervision, making sure all their imaging are done before their next treatment and all. So we have very good guidelines to follow, and I'm so happy that finally we are going in the directions where we are actually helping the patients and not just providing symptomatic management by treating their symptom, but actually fixing the root cause of those diseases. As I mentioned, we are general neurology, which is really vast. So it covers almost everything. So it can start from a stroke that the patients get discharged from the hospital. Again, stroke being a lifelong thing, need a very close knitted care in the outside world. So we take care of the patients who are discharged from the hospital, had developed a stroke, and how they're gonna go about it with the rest of their life, educating them, making them understand their risk factors, how they can improve some modifiable risk factors, providing them the care, and also advising them which other specialties they need to see, just like cardiology and other stuff, making sure that they are well supported with a multidisciplinary team. It can range from a stroke to neuropathies that the patients develop, from other comorbidities such as diabetes, or if unfortunately they had some sort of a cancer and received chemotherapy or radiation therapy, and now they are, suffering from neurological conditions such as neuropathy, providing them the maximum, relief from their symptoms, to, as I said, migraines and Parkinson's disease, Alzheimer's, multiple sclerosis, as well as in the pediatric or the adult side, we take care of ADHD, autism spectrum, and other neurocognitive disorders that I feel can sometimes be overlooked, which we make sure that we are paying extra attention to. I agree with you. I feel like ADHD is underdiagnosed because it's just not being hyper. We need to understand that it comes in a different types. Attention deficit hyperactivity disorder is one of the kind of ADHD. Then it is attention hyperactivity inattentive, and then there's a combined form as well where patient can be hyper and inattentive. A lot of time we do see an overlap on autistic spectrum or autism patients with the ADHD. So I have a very open approach to that. And for me, it's really important, first of all, to understand, is this what we are, dealing with? Because there can be other underlying conditions that can mimic that. It can be underlying depression, anxiety, or any medication side effect mimicking or making a patient feel like that they get overwhelmed in certain situations. So it trying to listen to them and understand where they're coming from, and asking them things about what are their biggest challenges that they're facing. Is it that, do they have trouble, for especially students, turning in their assignments in timely manner? Do they feel they get overwhelmed or not able to do multitasking? And also, like, for the kids, as getting the teacher's input, which is really important. A lot of time the kids are behaving differently in the classroom setup than are at home, and it goes in the adulthood too. Like, it's not just being in the college, but when you're in your professional life and you have targets to achieve and you're feeling behind, people think that it's them and they're procrastinating and they don't have the motivation. But I guess there are other elements to that as well. It's a common misconception that, and people get scared when they hear words like stimulant. So I don't want to be on one because A, it's a controlled substance, and they want to avoid it as much as they want to. But they need to understand based on what kind of ADHD they have, we have different options to offer them. We have non-stimulants that can help more with the hyperactivity part. Then we have the stimulants as well, which do work when it comes to inattentive, but we educate them that they will not be dependent on it, or they will not have trouble getting off of it, making them understand the half-life is short, they're very closely administered or are dispensed. Me as a provider who's able to write those prescriptions have very close monitoring. There are no refills allowed on that every time they go for dispensing the medicine. Even the pharmacy or us, we check when was the last time it was taken, and are making them understand if they want to take a break on the weekends, or it's a holiday time and kids don't need it, or you don't have, or you're on a vacation, you can easily not take it. So it's not like if you start on it, you're stuck with it for the rest of the life. So I feel like there's a lot of education that needs to be given, and understanding that the medicine is there to help you. We are not trying to get you on something, that you feel that, oh, now I'm on a controlled substance. No, it is there to help you achieve your targets. It's there to help you get to where you should be, which is now coming in the way because of the short attention span, or easily distraction, which again is not even your fault. So trying to understand the neurology, the chemicals, and helping them explain the real reason for treatment is to get to where they are struggling to be at. So I feel very good that I'm able to prescribe those medications to the people who actually need them, and then offer them different medicines, not just we're stuck with the Adderall, but there are so many other ones out there that can be given and help the patients in a positive way. I can positively impact patients' care at my practice by providing care that is not just clinically, but also based on being compassionate, consistent, and patient care. I want the patients to feel that they are being heard, explaining the conditions and treatment plans to them in a reassuring way where they feel empowered and not just helpless. Ultimately, my goal for patients being treated at our practice is to feel supported, respected, and confident that their conditions are being managed by not just expertise, but with the genuine care that we offer.